I truly do believe that was, in its best sense, shared decision-making between physicians and a patient.
And we need to assure that our operational strategies keep up with that momentum, or we'll find that we're not able to manage our patients in the way they deserve.
I am passionate about our need to build a learning healthcare system in the United States where we share patient-level data and use this knowledge to transform care.
When it comes to cardiovascular care on the organizational level, MedAxiom understands the challenges your program is facing. Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom HeartTalk. I'm excited to announce that we are starting a new Heart Talk series called Structural Heart Innovations. For this first episode, we will discuss the recent changes in transcatheter valve therapy, shared decision-making, and the power of data. To kick off the series, our guests today are Dr. Vinod Thourani, Dr. John Carroll, and Ginger Biesbrock. Dr. Thourani joins us from Atlanta. He is the Bernie Marcus Chief of Cardiovascular Surgery for Piedmont Healthcare and the Bernie Marcus Heart Valve Center, specializing in minimally invasive and transcatheter aortic and mitral valve surgery. Dr. Thourani is a national thought leader, active in a number of professional cardiac surgery organizations, including the Surgeons Council of the American College of Cardiology and the American Heart Association. He has authored more than 400 articles in a variety of prestigious medical journals. Dr. Thourani is passionate about working with a multidisciplinary team to provide patients with options for traditional, minimally invasive, and transcatheter surgical options. Up next, Dr. John Carroll joins us from Denver, Colorado, at the Anschutz Medical Campus at the University of Colorado. He has been director of interventional cardiology and professor of medicine at the University of Colorado School of Medicine from 1996 until 2021. Dr. Carroll has been practicing medicine for more than 40 years, trained well over 100 physicians practicing cardiovascular medicine, and his specialty interests include catheter-based therapies for all forms of heart disease and advanced 3D image guidance of interventions. He was the co-editor of the first textbook of structural heart disease interventions that has been translated into several foreign languages and is currently the chair of the steering committee of the Society of Thoracic Surgeons, ACC TVT Registry, the National Repository of Patient-Level Data on Aortic, Mitral, and Tricuspid Valve Transcatheter Interventions. Dr. Carroll is passionate about providing individualized care of the highest quality, compassionately delivered, and with open communication. And finally, we have Ginger Biesbrock, who you've all heard from before, calling in from Grand Rapids, Michigan, is the Executive Vice President of Care Transformation at MedAxiom. She combines more than 25 years of clinical and operational experience with the most recent scholarship in delivery science. Ginger's academic work includes a Master of Physician Assistant Studies from Grand Valley State University, also a Master's of Public Health degree from Michigan State University. She is currently a student in the prestigious doctoral program for healthcare leadership at the University of Alabama, Birmingham, with graduation planned for 2022. How exciting. I know you're looking forward to that. Her passion is to combine proven organizational performance improvement techniques with an innovation overlay, optimizing the present state while continuously looking to author original solutions. Welcome to the podcast, Dr. Thourani, Dr. Carroll, and Ginger.
Hello.
Thank you, Melanie.
Thank you, Melanie.
It is wonderful to have you all. So my first question that we ask all Heart Talk guests: why did you decide to get into healthcare? And did you ever have that aha moment? And Dr. Thourani, I'll toss that first one out to you.
Great. Thanks so much, Melanie. So my dad was a cardiologist in a small rural town in South Carolina. We had about 7,000 or 8,000 people. We had a Huddle House and a Hardee's, and that was about it. And I used to spend time I was a baby of 4 kids, and my father basically took everybody without, at that time, no insurance, didn't matter. And I used to work in his office ever since I was 12 years old. And that was my aha moment, just rounding with my dad and seeing the level of intensity that he had in taking care of cardiology patients. He would see 40, 50 patients a day. And that just set me into a pathway that that was just so rewarding, and seeing how patients loved him and how he took care of people and really made a big difference in their life. And that was really my aha moment, is spending time with my dad.
I love that. He must be so proud of you.
Yeah, yes.
Dr. Carroll, what about you? I know you have a personal connection as well.
Yes, Melanie, there were 2 aha moments for me. First, I grew up in a small rural community in Illinois, Mendota. In high school, I had a part-time job as an office janitor, and one day I dropped a large glass container holding drinking water and slit open my wrist.
Wow.
What a mess. In the emergency room, I watched in wonder as the local GP sewed together the tendons and artery in my wrist. Second, when I was an undergraduate at Princeton University taking biochemistry, our class took a field trip to the pediatric metabolic disease ward of Bellevue Hospital in New York City. Seeing children with the ravages of missing essential enzymes joined together for me the underlying science and the need to transform that knowledge into medical therapies. From that moment forward, I've spent the next 50 years in medicine.
Wow. What a transformative moment you had there as a janitor. What a 180, I would say. Ginger, let me ask you, because we've had you on before. It's always a pleasure when you join us. But in case someone hasn't heard from you before, would you mind sharing your story for listeners who might have missed it?
Sure. Thanks, Melanie. So there's probably multiple reasons, and this may very well be a different story, but a couple of things. We have a lot in common in that I also grew up in a small rural town in Michigan, in the Thumb, Marlette, and my mother was a nurse. She was an OB nurse, and she drove an hour each way every time she went into work, but she had a passion for the work that she did. And although I really wasn't exposed to what she did, I think just seeing the reward and the satisfaction that she had certainly spurred my interest. And then when it comes to cardiology, as a new PA student in my first internal medicine rotation, had the opportunity to assist or, really just learn about admitting, but we admitted a patient that had presented with a myocardial infarction and ended up requiring bypass surgery. And I had the opportunity to go into the OR, and standing there very nervous, first time probably ever in an OR, the surgeon invited me to scrub in and help him. And my portion of that assistance was literally holding the heart as he bypassed I believe probably the right coronary inferior portion. But that right there, to be able to see that patient journey from beginning through discharge, was probably momentous for me as far as developing that passion for cardiology and cardiovascular care.
Wow. I love it. You all have such similar stories. Just quickly, I'll share. My neighbors were dentists, and I used to be able to help them as a dental assistant. And I can remember one of the patients looking at me and be like, well, do you want to be a dentist one day? And I was like, no, there's too much blood. So I ran in the other direction, but it sounds like you all ran in the right direction and are doing big things. So thank you for sharing that with us. Dr. Thourani, I'm going to talk to you first. Taking a look at in the past 2 years, what are 1 or 2 of the most significant changes that you see regarding transcatheter valve therapy, or TVT, and how are these new trends affecting you and your care team?
So I would say that I was fortunate that only when I was 2 years out in practice is when I got involved. Even as a heart surgeon, I got involved with transcatheter valve therapy. So it was a great time to be in that era. That's around 2007. And so what I've now, having done TAVRs for over a decade, almost 15 years now, I'd say 1 or 2 things that have changed in the last 1 or 2 years has been the transcatheter movement into mitral and tricuspid valves. That has been absolutely mind-blowing to me, where I remember seeing hundreds of patients with mitral tricuspid disease that we were unable to treat with surgery, and we had no transcatheter options for them. And there were a lot of them were in heart failure and smothering and couldn't breathe, and we had no options for them. And just to see now, just for example, this past Friday, I did 2 transcatheter tricuspid valve replacements. John and I were on a call in the morning right before I did that. And both those patients have now gone home. They both have already feel better. That I never thought we would do that. And they were both treated with a needle stick. It has just blown me away at the movement of this technology. So I think advances in mitral and tricuspid repair and replacement, I think has just completely made me so happy that we could now touch a whole new group of patients that we couldn't before. So that to me is the biggest impact.
Wow. It's amazing to be able to work through that, I can imagine, and see and where will we be 10 years from now. That's exciting.
Yes.
Dr. Carroll, let me bring you in this conversation. It sounds like you all have worked together, or at least reflected on this before. So are you seeing similar trends in your program? And can you explain that?
Yes, Melanie. And I think my perspective is impacted by being in my 70s and really see transcatheter valve therapy as a major disruptive therapy in cardiovascular care. Valvular heart disease treatment had been stagnant for decades, and the only non-surgical therapy that I had learned in 1985 was microballoon commissurotomy of rheumatic microstenosis. And in fact, Eugene Braunwald, in one of his textbooks in the 1980s, suggested that valvular heart disease was declining as rheumatic fever was being prevented. When I moved to Colorado in '96, that was the state of affairs, and I was the only physician performing this treatment in a multi-state region. Now, with more transcatheter valve implantations than surgical valve replacements, there are more programs in a region than we really need, with almost 800 TAVR programs in the whole of US, and the number of patients with valvular heart disease has increased as a result of aging of the US population. And the other aspect that strikes me is the heart team approach. This has been a major collaboration between cardiology and cardiovascular surgery and valvular heart disease. And we were wise to foster this spirit and have a wonderful collaboration at the University of Colorado that optimizes care and contributes to the shared decision-making process with patients, with cardiologists and surgeons working together.
I love that.
And John, can I just add on to that, John? I think that when I started my practice, only 16 years, half of yours, but surgeons, cardiologists, it was a cantankerous relationship. And quite honestly, to see that change so drastically in both of our careers is really mind-blowing to me. And so it makes me so happy, quite honestly.
I love that. It's putting that ego aside and realizing that when we come together, we're so much stronger. Ginger, let me ask you. So a May 2020 paper published in the Journal of American College of Cardiology described shared decision-making for low-risk patients with symptomatic aortic stenosis. Step 1, team talk. Step 2, option talk. And then step 3 is decision talk. So can you explain why this process is so essential to helping providers effectively engage their patients in decision-making?
Absolutely. Thank you, Melanie. So I think first and foremost, shared decision-making is not steered decision-making. And it's really about empowering our patients, their families, as well as the clinical care team to make the most appropriate decision for that patient. Not necessarily the right decision, depending on who's wearing the hat or the decision-making, but coming together to make the most appropriate decision. There's really 3 objectives, if you will, that are met through a shared decision-making process. One is to identify that there's a choice to be made. So we have more than one choice to proceed. 2, to present the information on all the reasonable options. And then 3, to listen to informed patient preferences and really deliberate with patients and families, and that allowed for a consensus to come together around that particular decision making. The authors of that paper did a great job of outlining a good process, related to that team talk and having the discussion and what are my options. And then option talk and going into details to really understand the difference, the pros and the cons, the different sets of recommendations, and then finally being able to bring all that together to make a very informed decision. And evidence around these processes really show that informed decision and better shared decision making do go on to improve quality outcomes.
Mhm.
And I think it's just because we're more empowered. Patients understand the process, they understand what it means, what their portion of that process is, and so they can present with them and their families in a more engaged way. So I think it's a fabulous process. And again, the authors did a great job of outlining a good step-wise process to achieve it effectively.
Yeah, I love that. And I think you get that buy-in too, right? With families, when everyone's brought to the table to be a part of what comes next with that life.
Absolutely.
Yeah. All right, Dr. Thourani, I have a question for you.
I'm ready.
Can you share an example of when using the shared decision-making model has helped your patient?
I think that I think this is very important, and I think Ginger really made some very eloquent points on this, and it's not steered. I think that's really important. So I would tell you that we get a lot of patients, young patients, who have bicuspid aortic valve disease, and they come in and we discuss with them. And our surgeons at Piedmont Heart Institute in Atlanta, our surgeons, Dr. And the cardiologist, Dr. Yadav and Dr. Rajgopal, we actually see the patients together at the same time. So we're in the same room together at the same time. So there isn't a surgeon who comes in first and kind of sugar coats it towards surgery, or a cardiologist who comes in and sugar coats it towards a TAVR.
Mm-hmm.
We kind of are there together, and so we have family and two physicians together talking to them. And I will tell you that there have been a lot of examples where we have people in their 60s or 70s who have bicuspid valve disease. We propose to them all the advantages and disadvantages of surgery, all the advantages and disadvantages of TAVR, and we actually ask them what their preference is. So we're really giving them pros and cons for both procedures in durability, in structural valve deterioration, in perivalvular regurgitation. So all the things that are necessary for them to make decisions, and we make that really as a shared decision making. There's no ego in the room. If they choose TAVR, we move forward with that. If they choose surgery, we move forward with that. So I really believe that it is as equipoise as you could have it of a conversation. And that happened, I would say, twice over the last week, just on bicuspid aortic valve disease, TAVR versus SAVR. So I think that's a very poignant question that comes up to us quite a bit.
Let me ask Dr. Thourani, I'm just curious, do you ever walk into that room and feel like one way is better for the patient and then maybe they pick the other? How do you handle those types of situations?
Yes, we have. And I can remember a specific case when we had a young lady who was in her 30s, and she was resistant to having a mechanical valve done. We walked in that room thinking we're going to offer her a mechanical aortic valve at the age of 30. And that way, that was it. She wanted to have more children. And so when we walked in that room, the cardiologist and I both decided we were going to offer her mechanical surgical aortic valve replacement. We walked out of there and she ended up getting a TAVR. And so she said, I want to have children. I refuse to have a mechanical valve. I want a tissue valve. And at that point, we gave her the option of TAVR, SAVR. She ended up getting a TAVR, and we have consequently implanted her. She's now off her birth control and trying to have a child. I truly do believe that was, in its best sense, shared decision-making between physicians and a patient.
Great. It's a great story. So this does sound like a perfect place to press pause for a quick message for our Heart Talk listeners. As you know, MedAxiom HeartTalk is all about hot topics and candid conversations. For the first time, we are bringing Heart Talk to you live on October 7th and 8th at CV Transforum Fall 21. I will be taking you behind the scenes with the movers and shakers of care transformation as they discuss today's most innovative ideas and pressing challenges. If you enjoy an intriguing post-game interview with the conference's keynote speakers, these bonus sessions are for you. Register today at cvtransforum.com. Welcome back, everyone. So we have been having a great discussion about the current trends in TVT and really that shared decision-making model of listening to the patients and really the entire family. So let's turn to another vital piece of the puzzle, the data. Now, for listeners not already familiar with the STS ACC TVT Registry, it's a collaborative effort between the Society of Thoracic Surgeons, the STS, and the American College of Cardiology, ACC, to monitor patient safety and real-world outcomes related to transcatheter valve therapy. So, Dr. Carroll, let me start with you. You wrote in a recent article, what started as a means of tracking important information about a new and evolving technology, the STS ACC TVT Registry continues to be a valuable source of information, not only for showcasing how far we've come, but also for helping to determine where we're going in the future. So can you share a couple of highlights?
Yes, Melanie. With the approval of transcatheter valve therapies for patients covering a spectrum of risks for surgery, the TVT Registry has placed emphasis on developing risk models that can be used to not only predict the likely outcome for individual patients, but also assess the performance of individual programs. What we have been able to show using risk adjustment of outcomes on a national level is that outcomes have improved over the last 10 years, even for those patients at prohibitive risk.
Can you tell us a little more about that?
Yes, Melanie. From the quarterly TVT report sent to all sites, individual programs can see what sort of case mix they have in terms of low to prohibitive risk, and whether their results are similar to, better, or worse, using benchmarking results from all U.S. programs.
Wow.
This gives guidance to programs' efforts to continually improve the care of their patients.
I love that, putting the patient first.
Yes, it will continue to be important in the future as new transcatheter, mitral, and tricuspid therapies are approved.
All right, and let's look, towards the future, pulling that crystal ball, Ginger. 5 years in the future, what do you think the number one thing in terms of operational strategy that you think that CV leaders should prioritize as they run these structural heart programs?
I actually think there's two. So the first one is continued alignment with clinical leadership. And what I mean by that, and although I would agree, the collaboration between cardiology and cardiothoracic surgery in the last decade is worlds ahead than where we have been. That's not true for every program, and we have ways to go. And then as we are increasing our expanding indications, expanding into other valve type procedures, all of those, expansions, if you will, continue to require collaboration and continued discussion that then get built into the clinical strategy for the program. So as an administrator, it's really important to continue to foster those conversations and allow that to kind of work through and understand what that clinical strategy needs to be. Because what happens if we don't do that, we end up with some misalignment and things happening, and not everybody is rowing in the same direction, and we end up with missed care opportunities for our patients. And then I think in addition to that, the second area that feeds off of this first clinical strategy conversation is the operational structure that's needed in order to do that. So the other piece that I'm even seeing in programs now is their inability to keep up with the volumes of appropriate patients that need these procedures because we don't have enough hybrid OR space, or our cath labs aren't set up in the right way, or we don't have enough staffing to allow for the appropriate number of procedures, or our valve clinics don't have the ability for access to get these patients in. And so I think that continued combined, almost dyad leadership between clinical leadership and administrative leadership, and working very closely. There has been so much innovation, clinical innovation in this space, that unfortunately, I don't think our operations have always kept up with that. And our biggest limiting factor sometimes is our lack of facilities, our lack of staff, our lack of access to get these patients in. And so I think, again, to stay in front of all this, we need to foster that continued alignment between our clinical leadership, and we need to assure that our operational strategies around facilities and staff, people, processes, IT, all those sorts of things, keep up with that momentum, or we'll find that we're not able to manage our patients in the way they deserve.
It's clear that all three of you all, that your heart is in the work that you do and making sure that your knowledge is passed on as well. And it's a collaborative effort. Dr. Thourani, you frequently share cutting edge information with your peers. You do webinars on how to navigate complex TVT cases. Dr. Carroll, you lead the industry in explaining why evidence-based medicine and benchmarking are both so critical. And then Ginger, you travel all across the country, helping programs truly transform care in this space. I know sometimes it's hard to look at ourselves and say, hey, that's me. I'm a leader in this space. And, why are you so passionate about the work that you do? Dr. Thourani, let's start with you.
It's been an interesting journey for me. I've been passionate about the heart ever since I picked up Willis Hurst's textbook when I was, in my early teens. And then spending my time, over the last, 20 odd years doing it, it's been phenomenal for me. I'm passionate because every day I want to get here and I want to take care of people. And it's all about the patients for me. Cutting edge, cutting science. It's not because of the science that I love it. I'm passionate because I think I can provide our patients with something that's a great therapy and less invasiveness to them. And the more we can do that, I think we're better off. Seeing the joy of families. And I did a 103-year-old TAVR not too long ago, and a patient was 103 years old, and she drives a Mustang, a convertible Mustang. And her only comment to us was, I can't wait to get back to my Mustang convertible. Yes. And so that type of joy that you have 2 hours after a procedure and talking to your patient is just it's what drives us. It's what I come to work happy every morning, and I leave ready to see my kids, but sad that I'm going to be leaving for 12, 14 hours. So it's just a passion that I'm fortunate to be able to have, mainly because I've had great mentors who have helped me kind of become the person that I've become.
103, Dr. Thourani?
Yeah, she's cool. She was so cool.
Oh my gosh.
Cool. I love her.
Talk to her. That's amazing. Yeah. Wonderful.
Yeah.
Dr. Carroll, what about you? You've been doing this a long time. I can't believe you're in your 70s, and you have all this passion, and you're still learning.
John, I thought you were in your 50s, man.
I know.
I didn't even know. You look so damn young. I'm sorry.
I was thinking the same thing, because we have to disclose we can see each other during this podcast. So my mouth literally dropped when you said that you were in your 70s. So compliment to you.
Well, thank you. To be considered a leader in this space is profoundly humbling for me. This has been an opportunity for me to give back to the cardiovascular field beyond individual patient care. For decades, I have been guided by the work of others who have developed clinical management guidelines, run professional educational meetings, and run high-quality registries. As my career comes to a close, it has been fantastic to work with Dr. Thourani, Joan Michaels at ACC, Carol Crone at STS, and others in making the TVT Registry expand into areas like device regulation, patient-reported outcomes, and clinical research on patients excluded from the pivotal trials that lead to a device approval. I am passionate about our need to build a learning healthcare system in the United States where, via a registry, we share patient-level data and use this knowledge to transform care. Otherwise, we would be dependent on our own local experiences and case series reports from a few large medical centers. So this has been a wonderful journey that will continue as I pass the baton to others.
All right, Dr. Carroll, thank you. Dr. Thourani, as he pointed out, he has a 103-year-old patient who drives a Mustang. So you have some years in you, Dr. Carroll.
I hope to be driving my Porsche.
That's right.
Yes.
I love it. All right, Ginger, what about you? You do come with a different perspective, but as we've heard, throughout this time together, it's so important that all of these work together.
Yeah, I agree. I think I too have been blessed with a pretty amazing career path. Back in the day, had the opportunity as an APP to be part of some pretty high performing care teams that instilled in me the passion. Every single patient, we worked very hard to make sure they got what they needed and what they deserved when it came to heart care. And then as I can transition into more of administrative roles, my goal for myself was to try the best I could to assure that every caregiver every physician in our group, every APP, and everybody else on the team had what they needed to do their job most effectively, because that meant, again, those patients had the opportunity to get the care that they deserved. And in this role now, having the opportunity, I guess, to educate and foster and get in front of some pretty amazing things that not only get to, can hit many programs. So I kind of went from the patient to a lot of patients in a day with working with the teams and that I had to as an administrator, and now multiple programs that equate to that many more patients. And if anything that I can do to support the work that's happening and get you some forward thinking resources and tools and allow you to care that much better for the patients than you have, then that's my reward. So I am thrilled to be part of this work for sure.
Awesome. It takes a team. There's been a lot of head nodding during this podcast. That's a lot of really great information. So if you didn't get some type of inspiration or learn something today, I would suggest listening to it again. So Dr. Thourani, Dr. Carroll, Ginger, thank you all so much for taking some time out and sharing your expertise today on MedAxiom HeartTalk.
Thanks, Melanie.
Thanks, Melanie. It's our pleasure.
Thank you, Melanie.
That's it for this episode. If you liked it, please tell your colleagues and let them know they can subscribe to MedAxiom HeartTalk on Apple, Google, or wherever they get their podcast. If you'd like to send us a note directly or suggest a topic, email us at hearttalk@medaxiom.com. Thank you so much for listening.